Oh, is it on there? I thought it was on that big phone. Okay.
Yeah,
I guess that's all the matter it gets then. Okay, thank you.
You're welcome. It's been moved and seconded. Any additions or deletions or corrections to the minutes? Hearing none, all in favor, please indicate by saying aye.
Aye.
Aye. Pose same sign. So moved. Now we'll go to departments and ask if there are any comments to make with regard to either departments or just your report that you'd like to have.
Good morning. I'll answer any questions if anybody has any about the reports. We're still staying steady at about 17 vacancies. We did have a relatively successful job fair that was held on site on Saturday. We had about 13 applicants come in to be interviewed. Now we have to continue the process, so hopefully we get at least 5 out of the 13.
That'd be unreal.
Yeah. So
Wow.
that's what we're still dealing with at the facility. The other add-on is when Mr. Weber from Prime Care will speak, he's going to address the MAT, Medical Assistant Treatment, some concerns, and just speak a little bit on that program.
Okay. Anything else, Deputy Warden? Rebecca?
From the treatment end, I would just like to highlight we had some GED testing last week, and then we had another round this week, but we have one individual that has all his tests passed and he's going to be getting his GED.
Good for him.
Good. Any questions for the cabinet before we go to Tom's?
Well, I just wondered, Warden, I had asked you about a poster. Did you share that with the others? Maybe we should make them aware.
With the prison board?
Yes.
No.
Okay.
So Commissioner Litz sent an email asking for a poster, I believe, for CCAT for an event on August 3rd.
At our statewide conference.
And I believe the poster's intent was basically asking what the county or the correctional facility specifically was doing in regards to retention, retainment, hiring, and maybe some of the programming that we have been able to muddle through during the period of COVID. So actually, Director Richmond and Deputy Warden Davis have been compiling the information for a poster that we will present to Commissioner Litz so she can represent that at the event coming up in August.
Thank you so much. And again, there's an opportunity for staff to attend with that, but Tina says she's short, so that won't happen. But I'll make sure it gets posted when they're all displayed with the other counties.
Thank you.
You're welcome.
Any public comment? Anything else? Okay. Tom, would you like to?
Sure, just a brief update on medical, and I still feel obligated to mention COVID to start off with. Fortunately, we're doing well out of the facility. I think we had only 4 positives in June. We are seeing increases across our platform and other facilities. We're becoming resigned to the fact that we're going to have to live with COVID for the foreseeable future. You heard about the newest variant and the boosters and everything, and it's going to take the form of a yearly flu shot, most likely, that we're going to have, and we'll continue to offer. We had a clinic yesterday. Of the 13 people who signed up, only 5 actually received the booster, but we'll continue to offer that on a monthly basis. Recognizing that we are going to have to live with it, we've had discussions with administration about how we can resume work release in the not too distant future. As we've mentioned in this forum before, given the fact that it's not a separate building, it presents some unique challenges that we don't have in some of our other facilities. But the warden's done a great job of polling other counties, seeing what they're doing. So we'll be working together to see how that looks moving forward. Probably not next month, but beginning of the fall maybe we'll be in a position to do that, barring any significant law project. 2 weeks ago, polling all of the Pennsylvania counties, there is a lot of focus on this treatment modality in a prison setting. We're also starting to see patients' counsel advocating that this is the standard you have to provide it, and if you're not, you're providing below source in order to underwrite or offset the additional costs. If you're giving buprenorphine, Subutex, Soboxone, it's a labor-intensive drug administration, so as to cut down the chances of someone diverting it. You drink water beforehand, you do a mouth check, you administer the drugs. The individuals watch for 10 to 15 minutes. They're not allowed to lift their hands. They eat a cracker, they drink more water, there's another mouth check, and then they go back. And some incarcerated individuals are very ingenious in how they can circumvent some of the rules. So even with all those steps, you still can have potential
Shocking.
diversion. Yeah.
Wow.
One question about the, I guess the morbidity, is that the word for the population? This variant is not as strong. Is that maybe a reflection of our population age, or is that across all ages?
It's across all ages. I mean, you're still having potential cases with those who have comorbidities, but as a general rule, hospitalizations are down, ventilator use is down, but numbers are creeping up.
So, oh, I'm sorry.
Go ahead.
So, with regard to COVID, the people that are testing positive, are they newcomers to the facility?
Yeah.
So they're bringing it in essentially?
Yeah, and that's been the truth of the matter throughout. That's why we advocated, slowing down admissions, discontinuing programs with like work release, because you're going to have them coming and going. So everyone who comes in is administered a test upon arrival. They are quarantined for 10 days, and then they're tested again at the end of the 10th day before they're admitted to general population.
And do the inmates and the staff, are they wearing masks, or is that gone by the wayside?
It's heavily encouraged but not mandated at this time.
You done?
Yes.
May I ask another question or two? Unified Judiciary, that is of the state of Pennsylvania, that was sued by the Department of Justice.
Correct. Yes. Pennsylvania has a unified judiciary, so Lebanon's connected to Dauphin, connected to Cumberland, all along. So that is who they sued,
Okay,
rather than individual counties.
okay. And then the other question, or actually comment, is I think it was in the Daily News this morning, I saw where Lebanon's positivity rate is up 85%.
I was unaware of that, but it's increasing, and what's somewhat alarming about that is not only is it increasing significantly, but most testing has gone by the wayside.
Yes, they're doing home tests.
I mean, we're at least testing everyone who comes in, so we're getting a good capture. But out in the community, unless you show symptoms, and like I said, a lot of these cases are asymptomatic.
Understood. Okay, that was my two questions. Thank you.
Yes.
I have two short questions.
Would you
too.
mind
So,
introducing yourself?
My name is Beth Aminoff. The first is the decision to allow the medication like methadone or Soboxone, is that made at the county level or is that made at the state level?
That would be controlled by the county.
So that is a decision that would be made by the commissioners, whether they would like to begin to use it or not.
Correct.
Okay.
There is no mandate right now that it has to be done in Pennsylvania.
Or that it doesn't have to be done.
Correct. There's no prohibition.
Either way.
Correct.
It's not prevented. And then the second question is, I don't understand the medical part of it, but for people who are on, there's like a daily dose, is that how like methadon's every day or whatever you have to take?
Methadone is every day. Most forms of buprenorphine are every day, although there is an injection for buprenorphine Sublocade that is once a month.
That's what I was gonna ask about. Is that the Vivtrol?
No, Vivtrol is also once a month. Vivtrol controls opioid and alcohol effects on the brain. Buprenorphine is just an opioid. Sublocade is a form of buprenorphine that is injected once a month.
So would something like Vivtrol be another solution? Like to take somebody who was on, say, Soboxone, now they come into the prison, would it be possible to, instead of just right before they leave using it, but to use it while they're there?
There are a lot of options. People come into the program, into our facilities that are already on a program. You can continue them. There's what's called induction. If someone is assessed as suffering from an opioid use disorder, you can initiate the treatment. There are also questions of, you can initiate it shortly before release, to try and get them steady on their way out. So there are a lot of different forms it can take.
Is one any more expensive than the other? I mean, does cost factor into this?
Cost does factor into it. It's a complicated process to analyze the cost. As I said, administration of Subutex or Soboxone is very labor intensive. Sublocade is once a month, and by way of example, Soboxone and Subutex are very, very inexpensive, less than $1 a dose. Sublocade is $1,800 a shot, approximately. There's a lot of grant programs right now there is for Vivtrol where you can get it. Unfortunately, it may take multiple incarcerations before you get to that point, but we have a lot of people who recognize heroin or opioids are going to kill them at some point, so they're prepared to stop that. Unfortunately, we'll have discussions regarding the use of Vivtrol, and when they find out they can't drink anymore, they're not interested in the drug anymore. So that it's a challenge, and we could spend the rest of the afternoon hashing out the issues that are involved with these type of programs, because one of the questions, if they're an addict, they're likely to relapse. So what happens when they cheat on the program? Do you kick them out automatically, or is your philosophy that's what we anticipate them doing, so you get a second chance, a third chance? How does it go? There also needs to be a counseling component of any of these forms of administration, because it's not just the medication, but you got to alter the mindset that is addictive in nature. And you'll have individuals who, I'll take the drug, but I'm not sitting down with a counselor. Well, how do you reconcile those if that's the form of treatment requires both?
And just one last question. So right now, Pennsylvania is not obligated nor prohibited from doing the MAT.
Correct.
Is it your estimation that the resolution of this DOJ case is probably that Pennsylvania is going to have to implement it?
Well, the DOJ case is limited in its application because it's just dealing with the work release aspect. It isn't as broad as saying someone who has this diagnosis should be receiving these medications. I firmly believe it's going to be plaintiff's counsel that will push the ball, and there'll be case law, perhaps before legislation, that says people like our providers, you can't provide below the standard of care, and if you come in and you're on a program, and let's say you get released from jail, evidence shows that for those first 2 weeks, if you're an addict, you're at a significantly higher chance of an overdose death because you've been off of it for some period of time. You go back using the same number of bundles you did before, and you OD because your tolerance hasn't been built up. I can see someone coming to us, the county and prime care, and saying, you should have put them on this drug. You diagnosed them as having an opioid use disorder. You did not. Your failure to do so is what led them to overdose when they're out.
Of course. Okay. All right.
Just one more. So in your opinion, are you a doctor?
No. Well, I have a doctorate, but I'm not of medicine.
But not of medicine. But in working in the field that you do, is it your opinion that it would be good for the county, like I've heard you mention this now in a number of meetings, that it would be good for the county to move that direction? And then if so, who prepares all the information these people would need to even begin to make a decision on what's what? How would that work?
I believe there is sufficient evidence-based medical data that shows that these treatment forms can be helpful. I've spoken with administration. As for the data, I've promised the warden that I'll get more information, because we have this operating in a number of our facilities. So we can look at statistical data with the number of people that are coming in that report opioid use. What's the likely size of your program? What's the likely cost of the program? Do you need an additional CO or two to handle these drug administration? And as we're aware, it's easy to say that this is a good program. It's much more difficult to implement it from a resource standpoint, from a manpower standpoint, with everything that's going on in our correctional facilities. So it's not far akin from the mental health crisis we have. We don't have resources in the community to address that, and we become the de facto mental health hospitals. We're now becoming the de facto substance abuse treatment centers. And both methadone and buprenorphine were enacted at a time, or were approved by the FDA at a time where there was still a much more heightened level of scrutiny. The concept of a drug for a drug was much stronger back then. So the regulations make it very difficult to administer these medications, and they make it difficult to administer it in a correctional facility. By way of example, there are exceptions to administer buprenorphine in a nursing home that do not exist in a correctional facility. And the reason it's allowed in the nursing home is that SAMHSA and the FDA have determined, because of the greater security in a nursing home, we're allowed to administer it there as opposed to like a doctor's office. But they don't recognize that we're a locked facility, so